Hi, buddy. Dr. Daniel, and today I'm speaking about a rare problem with migraine called familial hemiplegic migraine. One of the worst things a migraine headache can do to a person, besides giving them a terrible one-sided headache, along with nausea, vomiting, sensitivity to light and sound, the need to be down, would be to cause paralysis on one side. But migraine can do that, mainly only in boys born with the familial hemiplegic migraine gene. It's very rare. This is what the International Classification of Headache Disorder states for familial hemiplegic migraine. It should be migraine with aura, including motor weakness, and at least one first or second degree relative has migraine aura, including motor weakness. So you got to have it in your family. What related questions? What are the genes that come with familial hemiplegic migraine? There are three kinds of familial hemiplegic migraine, each with different genes involved now, but probably there'll be more of these in the future. FHM1, FHM means familial hemiplegic migraine. FHM1 has mutations on chromosome 19. FHM2 has mutations on chromosome 1. And FHM3 has mutations on chromosome 2. As I've said, there may be other loci which are not yet identified. What type of inheritance is associated with FHM? It's generally an autosomal dominant type of inheritance, although some cases have had a sporadic inheritance. Autosomal dominant inheritance means that one half of children have a chance of getting the genetic makeup for this illness. What triggers an attack? Mild head trauma sets off an attack in 50% of families with this gene disorder. Is an attack of FHM confused with other neurologic problems? An attack of FHM comes with brainstem involvement along with typical migraine with aura symptoms. An attack may be confused with epilepsy and treated as such, although anticonvulsant treatment doesn't help. Disturbed consciousness, coma, confusion, fever, and CSF pleocytosis may occur. Problems with attention and memory may last months after an attack. Some cases developed delayed cerebral edema, a serious neurologic problem after minor head injury. There may be an overlap of other neurologic conditions with FHM, including episodic ataxia type 2, spinocerebellar ataxia, benign familial infantile epilepsy, and alternating hemiplegia of childhood. Are there any long-term results after attacks of FHM? 20% of patients may develop ataxia, which involves trouble coordinating limbs or falling while walking. Some patients with chronic attacks develop nystagmus, which is a rapid vibrating eye movement problem. What in the brain causes the one-sided motor weakness? That is, what is the pathophysiology? Like the typical aura of migraine with aura attack, which causes visual attacks, numbness, and trouble talking, the motor paralysis is thought to be due to cortical spreading depression. This is an electric short-out of the brain that moves slowly across the cortical surface, causing the symptoms mentioned, and then the brain resets. Cortical spreading depression is a self-propagating wave of neuronal and glial depolarization that spreads across the cerebral cortex. What's the result of neurologic workup for FMH? EEG testing, looking at physiology of the brain, may show slowing the brain on the side opposite the hemiplegia present during the attack, which then clears up. MRI scan also may be normal, depending on the timing of the scan, relation to onset of symptoms. Some scans show cerebral edema with cortical enhancement and T1 gadolinium enhancement, which goes away on rescanning. And on my webpage article about this at drmigraine.com, I have a picture of a brain MRI with this condition. How is the diagnosis of FHM made? The diagnosis is made according to these criteria. You have to have 2 attacks of it. There should be R with motor weakness accompanied by either reversible visual symptoms, that is flickering, lights, spots, lines, etc., reversible sensory symptoms like pins and needles, numbness, feelings, or speech symptoms. At least 2 occurrences of 1 or more R symptoms that develops over 5 minutes. These symptoms lasting more than 5 minutes in less than 24 hours. Headache beginning within 20 minutes of our onset. These headaches can last 4 to 72 hours, occur on only one side of the head, pulsate, be of moderate to severe intensity, and may be aggravated by common physical activities such as walking. These headaches may also be accompanied by nausea and vomiting, photophobia, and phonophobia. At least one close first or second degree relative has FHM, and there's no other likely cause for this. Sporadic forms follow the same diagnostic criteria with the exception of the family history, so they've got it, but we don't know where it comes from. What's the differential diagnosis of FHM? Other neurologic conditions and considerations could be migraine stroke, CADA-cell, which is cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy, or cerebellar degeneration. Is it possible to genetically screen with blood work for FHM? Prenatal screening is not done, but it may be done screening for a younger child because penetrance is high with this disorder. What is the management of FHM? Advice to avoid minor head trauma and activities that cause this should be given. Contact sports should be avoided. Ergotamine or triptans for acute migraine treatment should be avoided. Acetazolamide has some effect along with using just minor analgesics such as NSAIDs, caffeine, ibuprofen, or naproxen. What is the epidemiology of FHM? Migraine occurs in 15 to 20% of the population, while FHM occurs less often at a rate of 0.01%. Very small number of persons with this. So thank you for listening to this. Hope you don't have this condition. God bless all you folks with migraine. I'll see you again on the next talk. Please click on subscribe. Thanks. Bye.